Okay, good afternoon, everybody. I'm going to present on the update of the PrEP and PEP guidelines. We all know that PrEP is a crucial tool for HIV prevention for people who are at the risk of acquiring HIV. But before starting the guideline updates, I want to share a few words about the situation of PrEP globally and also in the region. Our current global target is to have 10 million PrEP users by 2025. While progress has been made, but still end of 2022, there are over 2.5 million PrEP users globally. Now, let's take our attention to the region. The regional target for 2025 is to have 4 million PrEP users, but estimated users by end of 2022 was only 150,000 people. So this means we have achieved only 4% of the target, 4% of the target, leaving a gap of 96%. Now let's move on to the guidelines. Now for PrEP, it's over a decade when the first guideline came in 2012, and 2015 was when the guideline came out that suggested PrEP for all at substantial risk for HIV. It is important to note that the guidelines continue to evolve based on newer evidence and products that are coming to the market. And these guidelines are not just clinical guidelines, these are also program implementation guidelines. And today we are going to focus mainly on the differentiated PrEP guideline and the DVR and the CAB-LA guideline, and I will also touch upon the PEP guideline. Let's start with the oral PrEP guidance. I'm sure many of you are familiar with this, but I would like to highlight a few items here. The goal of this guideline is to make sure PrEP delivery is easier and more convenient while maintaining quality and safety. And there are 5 of these key areas. I will go over each of them. First is the oral PrEP and kidney function tests. In summary, anyone below 50 without comorbidity testing testing for serum creatinine is optional. And if available, one can conduct it once in 1 to 3 months of initiation and repeat it depending on the results every 6 or 12 months. Now, this guidance applies to both doses of PrEP. It's also important to note that DVR use does not require kidney function tests, and no kidney toxicity is anticipated during the use of CAB-LA. But what is most important to note, waiting for kidney function test results should not delay starting of oral PrEP. And if the results come, they can be reviewed at a follow-up visits, unless and until it is very abnormal. And by abnormal, I mean it's below 60 ml per minute. And if you see the abnormal test results, it has to be repeated on a different date. And usually it returns to normal after the stopping of PrEP. Now, hepatitis and oral PrEP. PrEP services offer an opportunity to address hepatitis. TDF-based oral PrEP and DVR can be safely offered to people with hepatitis B or C infection. But tests are not a requirement for PrEP initiation. HPV testing is strongly encouraged within 1 to 3 months of PrEP initiation. And if the person turns positive, one has to refer for management. And similarly, for hepatitis C, testing is also encouraged at or within 3 months around initiation, and then repeat every 12 months only for those who are at high risk of HCV infection. Now, HPV and HCV testing should not be a barrier to PrEP services, and CAB-LA should not be initiated in people with advanced liver disease or acute viral hepatitis. Let's move on to self-testing and PrEP. This is the latest recommendation. We know that only testing requirement for oral PrEP initiation and continuation is HIV testing. Now we know that HIV self-testing is a game changer for testing programs and potentially for PrEP programs, especially for oral PrEP and DVR. And therefore, WHO recommends that HIV self-testing may be used to deliver pre-exposure prophylaxis during initiation or re-initiation or continuation of oral PrEP. Role of self-testing with CAB-LA is unclear. But HIV self-testing can support differentiated service delivery approaches for oral PrEP, such as delivery outside the health facilities, reducing clinic visits, particularly for follow-up. This is also, it also supports PrEP services and may be preferred by users for convenience, privacy, and self-managed care. These models may have the potential to remove barriers to accessing PrEP and thus increasing uptake, persistence, and effective use. And HIV self-testing is also likely to be great for DVR use, where the development of drug resistance is not a concern. Let's now move on to the oral PrEP dosing. We have to look at this dosing slightly differently because the dosing is based on groups of people. So oral PrEP dosing for all men and transgender women, not on hormones. They can start with 2 tablets 2 to 24 hours before the potential exposure, continue to take 1 tablet a day while having the exposure, and then take 1 tablet a day for 2 days after the last potential exposure. This dosing is only for sexual exposure and for TDF-based PrEP. Most importantly, it can be used for one event, which we conventionally call ED PrEP, or for continuous use. And hepatitis B is not a contraindication. Now the oral PrEP dosing for everyone else, and this group comprises of all women, transgender men, transgender women on hormones, persons who are injecting drugs, as well as also other gender diverse people. They can start by taking 1 tablet a day per day for 7 days before the potential exposure, continue to take 1 tablet per day while having exposures, and while stopping, they need to take 1 tablet a day for 7 days after the last exposure. This is for the sexual exposure as well as also for exposure through injecting drug use. This is the same thing, it just shows in a simplified table. There's a population, how they can start, how they can continue, and how they need to stop. Now, the differentiated services, these services are usually person and community centered. It is adapted to the needs and preferences of the people. And what it does, it takes PrEP closer to the people and addresses their concerns. There are 4 main building blocks, and these can be used for initiation, follow-up, reinitiation, as well as switching between the products. One of the key things for this DSD is task sharing, but it requires proper training as well as oversight. These approaches have shown to increase PrEP, and I'm not going in details about it because the Philippines is already doing it. This is another update which you may want to look at. These are how the services can be integrated, and this is an example from STI and PrEP services. And it's important to note that PrEP offers an opportunity for STI diagnosis and treatment, and similarly, STI services offer an opportunity for PrEP use. Now, moving to the newer PrEP products, the dapivirine vaginal ring and the cabotegravir long-acting injectable. The ring is a discrete prevention option for women. It's a silicone ring which has dapivirine that can be released into the vagina over a month, and the risk of infection is reduced 24 hours after insertion. DVR can be recommended as an additional prevention choice for women at substantial risk for HIV infection as part of combination prevention approaches. Evidence from the clinical trials demonstrates safety and efficacy. However, the open-label extension studies suggest higher efficacy. Adverse events are very rare, and there are no drug interactions with contraceptives, and even it's safe to use during pregnancy as well as during breastfeeding. The cabotegravir long-acting injections, WHO recommends these may be offered as an additional prevention choice for people at substantial risk for HIV as a part of combination prevention. It is an intramuscular injection that is given every 8 weeks, with the first 2 in 4 weeks apart. Values and preferences among communities show that CAB-LA can provide an opportunity to address adherence-related challenges of oral PrEP. However, there are several critical gaps that needs to be addressed. For example, the use of CAB-LA among transgender men or people who are engaged in sex work is unclear. So is the safety during pregnancy and breastfeeding, the HIV diagnostic testing schedules, antiretroviral resistance, and things like that, as well as also shifting between the PrEP products. Now, the PEP or the post-exposure prophylaxis. PEP should be offered and initiated as early as possible for individuals who are, who had an exposure, and that exposure that has the potential for HIV transmission within 72 hours. A 2-day regimen of TDF FTC or TDF 3TC is effective, but 3 drugs with the additional dolutegravir is preferred. There are some issues with PEP in HIV prevention that we need to be aware of. That knowledge about PEP is low in the groups that are affected by HIV. There is limited and medicalized access of PEP only, and it often starts late, and incomplete treatment are some of the major issues around PEP. It is important to have adherence support for PEP and a full 28-day medication during the first clinic visit. And most importantly, while thinking of prescribing of PEP, one should think about STI and emergency contraception use. Transitioning from PEP to PrEP is also important to be considered. One needs to discuss this with the people who has come for PEP, whether they have repeated exposure to HIV, and discuss if they may benefit from PrEP. If so, there should be an immediate transition without a gap, but with a negative HIV result. Those on PrEP, if they take PrEP as prescribed, they don't need PEP. However, if it is not taken or directed, if it is not taken as directed or it has been stopped abruptly, there may be a risk of HIV acquisition. In such clients, the PEP can be considered after a thorough assessment. Now, in summary, WHO PrEP guidelines have incorporated all the 3 products. It includes simplified differentiated guides, simplified testing and dosing, the new HIV testing schedules, integrated service delivery, and things like that. The PEP guideline is also getting simplified, and it's in the pipeline. It will be released during the IAS, upcoming IAS. And but we also have to understand that that PEP is an underutilized prevention option, and one has to strengthen the PEP to PrEP, and also the package of PEP services are also getting considered. So that actually brings me to the end of my presentation. Thank you for listening. And this is the team which has been constantly working on PrEP, and any questions or concerns we'll be happy to address. Thank you very much.